What is up, Clinical Athlete Journal Club peeps? Hi, Taylor. All right. While Kevin figures out how to use his camera. Oh, okay. What's up, buddy?
Not much. How is everybody?
I'm doing well. How you doing, Taylor?
Well, good.
Wow.
Whatever the word is.
Yeah. Well. Okay. Sweet. So here we are. Happy Friday. We're going to get started. And if you are not familiar with Clinical Athlete, or this is your very first journal club, welcome. As far as participating, you've got a few options. You can raise your digital hand if you have something to say. There should be an icon there where you can kind of request that we unmute you, and you can actually talk like a radio show. It won't turn your camera on. It'll just be your voice, but you can kind of call in with your comment or your question and we can discuss it. If you want to do that, but in text form, then you can use the Q&A box in your Zoom panel. So if you have a question that you want us to address in the discussion, put it in the Q&A box. You'll also notice that there's a chat box. The chat is where you guys can just have free flowing conversation. So if you've ever been on like a live Facebook or live YouTube event and they've got the live comment section is just kind of going, that's the chat section. You can use that however you want. It's been pretty useful for people in past meetings because you guys will share links with each other and references and stuff like that. So it's pretty cool. But if you put a question that you want us to address in the chat, we may miss it because it'll get kind of buried. So make sure you put those in the Q&A box. Or you can just listen and soak up the conversation as a fly on the wall active listener, and that's great too. These meetings are open to anyone who wants to join in. We do record them and put them in the Clinical Athlete Forum along with all the other great resources there for athlete health and performance. So if you want to check out the forum, I have just posted the application link in the chat box. Now, there it is for you. And I'll also post the link to the PDF to the paper that we're going to discuss tonight in case you didn't get a chance to download it. I'll put that in the chat as well. So that's a PDF link that you can download the paper that we're going to talk about. And then one more quick note on sound. If you were, let's say we unmuted you and you were joining the discussion, if you're no longer talking, just try to remember to mute yourself again because some of your background noise can come through and be distracting. So just keep that in mind. And we need a meeting scribe. So when we record these meetings, we put them in the forum, but then we like to have kind of show notes to summarize the key points for people who weren't here, they can follow along. So if anybody would volunteer to be our meeting scribe, it doesn't have to be crazy. Like if you're already taking notes during the meetings, like just little bullet point summary in summary form, shoot that to me at info@clinicalathlete.com. I'll put that email in the show notes as well. And then we'll be able to share that with our post in the forum, and it'll be very helpful for people. So if you have a volunteer for that, shoot me an email. With all of that said, welcome to the Clinical Athlete Journal Club number 23. My name is Quinn Hennick, and I'm a proud clinical athlete provider. And I'm joined by Kevin McNamara, who's a physical therapist currently completing a residency at Johns Hopkins. He's a longtime Clinical Athlete Forum member and the one responsible for bringing this journal club to life. So thanks for being here. As always, Kevin.
Of course, Quinn. I'm dragging a little bit this week, but we're going to end on a high note.
There you go.
Paper.
Yeah. Strength training, man. Come on. Doesn't get any better if you can always just kind of fall back on your laurels, you know? And we're also joined by clinical athlete intern Taylor Allen Flanick, who is a doctor of chiropractic in New York State. How you doing, Taylor?
Good. Thanks for having me.
You said good instead of well. You were well before, but now you're good. I don't know if that's an upgrade or a downgrade.
I don't know either.
Grammatically or okay.
It's a sidestep.
Yeah, we're glad you're here. Taylor helps us a ton with curating all the questions and keeping the discussion going forward. So we've got a great team here to lead the way. And if you're curious about the impetus of these meetings, way back in the day, a smart guy named Benjamin Franklin started a weekly club that was called the Junto Club. It was a, quote, mutual improvement club, but it was basically just a room of really smart people discussing topics and issues of the day. And they had an important policy, and that policy was that all discussions would be conducted in sincere spirit of inquiry after truth without fondness of dispute or desire of victory. That's become our Clinical Athlete Journal Club motto. So we're all on the same team, and we're just out here trying to be less wrong. Okay, tonight's Journal Club topic is strength training. And the name of the paper that we're discussing is The Benefits of Strength Training on Musculoskeletal System Health, Practical Applications for Interdisciplinary Care. And again, you can download the paper, just click the link in the chat. Taylor made a few poll questions to get a feel for the crew that we have here tonight. So I'm just going to launch those, and they should pop up right in front of your face. The first question is, who are you? Clinician, student clinician, coach, trainer, student coach, trainer. So if you've got a quick second, answer those questions. The second one is, do you regularly encourage or utilize strength training for your patients/athletes? And if not, has this paper inspired you to encourage/utilize strength training for general health purposes? There's no right answers. Just be honest. It's anonymous. So it looks like about 50% clinician, little under 50% clinician, little over 40% student clinician. So most of the people in the house are either clinicians or future clinicians. And then we've got some coaches and some student coaches too. There's no option for clinician and strength coach. Good point, Michelle. But it's a clinical athlete, so we'll just assume. We'll just assume you're both. And if you're not, after reading this paper, you probably start to be somewhat of a strength trainer coach. Cool. And then most of you, all of you said that you do utilize or encourage strength training in some capacity. And we were inspired after reading this paper. Cool. Okay. So the paper was not a research study. It wasn't a randomized controlled trial or an observational study or anything like that. It wasn't a systematic review or a meta-analysis. But what it was is a review paper that kind of summarizing the evidence around strength training and kind of a health and musculoskeletal health lens, which is useful definitely for the rehab space, but also for coaches and trainers, looking to kind of have some support for some of the things that you do. So the introduction was kind of going through the importance of strength. And I say this a lot with a lot of papers that we talk about, but one reason I love papers like this is that the paper itself becomes a reference for you that you can continuously go back to. There's over 200 references in this paper, and it really spans the rehab to performance side of things. And so if you're looking for certain topics, like you could probably go to this paper and then pull references from their citation list and do lots of digging in that regard. So this is a type of paper that becomes kind of your go-to, when you're searching for information on this topic. But they go into the importance of strength and athletic performance. Is kind of how they start out, which, we have evidence to kind of support that in regards to rate of force development and jumping ability and sprinting ability. So essentially, if you can produce force, it helps you produce force fast or produce a lot of it if you need to. You have to have that ability. And that's kind of how they defined strength in this sense, is the ability to produce force, the ability to resist an external resistance. And then kind of getting into why the impetus of this paper, whereas there's less evidence or less discussion in regards to the mechanisms and benefits of strength training in kind of the health and rehab space. There's still some, which obviously they cite, but there's less. And so that's kind of the introduction here. And I'm just kind of going through my notes, but then the aim of the paper, they go into the end of the introduction. The aim of this paper was to provide practical recommendations in line with best practice for healthcare professionals involved in orthopedic and sports medicine. And then the next section of the paper is talking about the mechanisms. And I think one of the main mechanisms of strength training and how it affects the body is this term mechanotransduction, which you can kind of read in the paper, and they cite some other papers that you should probably read if you're interested. But essentially mechanotransduction is how the cells respond to mechanical loading and the cascades that happen after you introduce mechanical loads to tissues, be it tendon, cartilage, bone, muscle. And not necessarily that helps us clinically, which we might have a conversation about, but just kind of the underpinnings. It's not strength training, I think, is a big point here, and one that I talk about a lot is it's not like we're saying there's a strong enough. Like if you won't get hurt if you're this strong, or you'll get out of pain if you get to this amount of strength. It's more of the process of applying stresses to the cells and to the tissues and to the system and to the organism over time that these changes start to occur. And mechanotransduction is a response to mechanical load. So they kind of go into the underpinnings of that. And we'll dig in. I just want to do a quick overview, and I'll throw it to Kevin and throw it to the rest of you guys. But then what was cool is in section 3 of the paper, they go into the effects of strength training on individual tissues like tendons and cartilage and bone and muscle. And you start to see that mechanical load might have there's different ways to dose it. And different dosages can have different effects based on the tissue. So lighter loads may have different effects if we're talking about tendon versus muscle. Frequency, intensity, these types of things might have different effects if we're talking about muscle versus bone. So this is why it's important to tease these things out. And then the last part of the paper was more kind of practical recommendations on some programming things. They give a bunch of a few different cases on just kind of an overview of multidisciplinary management of certain cases, young runners, older active individuals, older non-active individuals. And so I'll stop there, and then we can kind of get into some of the nitty-gritty of the paper and some of the concepts here. But Kevin, what do you think about this one just overall?
Yeah, I mean, I gotta be honest with you, man. This is probably one of my favorite papers that I've read recently.
I appreciate you being honest with me.
Especially even this author group, right? Because we had another paper from them a few meetings back. And what I really appreciated about this, and what I think this group does a really good job of in general, is, okay, they're laying out all this sort of background information, giving you insight and details into some of the basic science elements of resistance training that you can kind of utilize to inculcate the values of it, whether it's from a patient education standpoint or even just communicating clinician to clinician. But then what I really liked was the sort of avatar breakdown that they kind of put forth towards the end of the paper. And to me, I thought this was excellent because it's really kind of what we do as clinicians, rehab professionals, strength coaches, whatever it may be, is kind of considering, okay, where is this person at from a general health perspective? What things do I maybe need to be aware of that may have a positive or a negative impact on their outcome? From a musculoskeletal system, perspective, what are we dealing with? What's the tissue? What's the injury, et cetera? Are there various psychological factors that could be playing confounders in this? What's their social and lifestyle habits? Because we know that that's kind of positively or negatively impact kind of treatment plans and training in general. What's this person's history? What sort of training variables are going to be most beneficial to them? And then various genetic factors as well that can all kind of result in a positive or a negative outcome. And what it really speaks to me about is just that the real value in my mind with resistance training not only comes from its ability to have an impact on, a myriad of systems, but kind of the infinite scalability of it based off of that person that is kind of sitting in front of you. And I think this paper did a really phenomenal job of kind of bringing all of those points together and providing something that is not succinct, but it's actionable enough to get you kind of moving in the right direction and how we can actually implement these things from a practical standpoint. So that was kind of the real thing that I thought was a real positive for this paper.
Yeah. And I think if we're probably working in kind of an echo chamber here with, with our community and the people that tune into these meetings and stuff, and everybody chime in whenever you want to raise your hand or shoot a question. But I thought one of the important points here is we talk a lot about how we tend to underload our patients, and they brought forth some evidence to support that not only is underdosing maybe prolonging the process, but sometimes if we're underdosing, we're not getting the effect. Like, we're not having an effect on the tissues and on the system and on the organism. And that there are starting to be studies now comparing these things in different populations. So they cite the Lift More trials with, in this case, it was the postmenopausal women, and showing changes in bone mineral density with higher loading. Programs that look a whole lot like what I would write for my young kids high school kids at the gym, compared to maybe what we would like not doing it at all, or doing maybe a more traditional higher rep, lower load program, which, by the way, could probably build some muscle, but when it comes to tendon and bone adaptations, maybe not. And so I'll dig into that a little bit. But so I thought that point was well taken, that the process of progressive overload needs to be that, obviously starting light and having an introductory phase, which they talk about over the course of the paper, is important. Like, you're not going to just put somebody into the deep end of triples at 85%, repping out deadlifts, but at some point the process needs to start nudging that direction so that you can actually get physiological adaptation, so that you can actually get the mechanical stress needed for these tissues to adapt. And sometimes as clinicians, we can be a little scared, for lack of a better term, because we don't want to hurt people, especially when it comes to somebody who's osteopenic or something like that. We think about doing like jumps and impact movements. We're like, holy crap, that's scary. You can think about that. But the other side of it is, if they're not going to get it with you, who's a professional and in a very safe environment, they're not going to get it at all. So, as professionals in our space, we need to get more comfortable prescribing these things, prescribing the appropriate way to implement something like that. And they give some good examples later on in the paper, kind of a breakdown of programming examples. But I thought I liked the part 3 when they start to break down the effects of mechanical load on certain tissues. The cartilage piece, the beginning of that section 3 was eye-opening, where it seems like cartilage adaptation, positive cartilage adaptation, cartilage seems to be the tissue that's affected the least with strength training, but we can at least mitigate loss. So they did show that if you strength train, it doesn't necessarily make your cartilage that much better. But if you don't do anything, if you don't load bear through those tissues, then you do lose some robustness through those tissues. So like, at least we're, keeping the status quo and keeping the tissue there, because you're subjecting it to load. And citing some of the research with once you have OA or something like osteoarthritis, keeping your force production, keeping your muscle mass is a good idea. May not prevent it, but
yeah, I think you make a really good point, kind of with regards to, how much are we actually loading patients to really kind of get this. And they kind of dive right into this early in the article, making the sort of distinction between like, quote unquote, strengthening programs and strength training. And I think that's something that, I don't know if it's missed or if it's just a lack of understanding around that, but I think maybe that kind of needs to come from a place of, what are we actually after here, right? So if we're looking to make true tissue adaptations, like you said, then there needs to be some semblance of load induced into the program. And I think it may become a little bit like a hang up on semantics, but I think it's important to understand that distinction between, strengthening where a person is maybe improving the amount of load that they're lifting in a specific pattern because they're just becoming more efficient from a neuromuscular standpoint, versus like a strength training program where we're actually going after specific tissue adaptations. I think if you can understand that, that goes a long way in actually facilitating a more efficacious rehabilitation process, or at the very least, you're probably going to be more accurate with regards to some of the things that you are implementing or prescribing.
So would you say then that you can start relatively generically? Let's assume this person is an untrained individual and or at least deconditioned, because even a trained individual, if they're coming to you having not trained for many months, they have some beginner gains to be made almost. But let's say they're in one of those two camps, then then it's any strengthening in the beginning. You literally could do anything, and that neuromuscular system is going to start to learn how to click again, and you're going to kind of get those beginner gains. And you don't have to be too nuanced. You'd be pretty generic with that. 3 sets of 10 will probably get you some gains in the beginning. But then to your point, then strength training, once you've kind of tapped out those just beginner gains, the neuromuscular system figuring out how to even synchronize the muscles and the agonists, antagonists, and synergists, so they go into all these things, and your motor units rate coding becomes more efficient, and you can start to learn how to fire, the entire pool of motor units. Basically, people learn how to produce force, like the force that they had. But at some point, if you want to actually then create more capacity to do that, then you have to be a little bit more specific with your parameters and nudge a little bit more into what we would think is going to produce more force, which are higher intensities. Is that kind of, yeah.
100%. And where I think this gets kind of murky is because we always have, things like natural history and regression to the mean that are kind of confounding some of this stuff here. And it just makes me think here, okay, we're introducing someone to resistance training for the first time, and we're seeing some of these changes or gains made, positive changes in objective measures. It just makes me wonder are we really making much of a change, period, if they're coming to us with something that is maybe tissue related or structure related? And are we maybe sort of sending them on their way out of rehabilitation without a proper understanding of continuing sort of this training process, to where are we maybe having the wool pulled over our eyes with things like natural history, regression to the mean? Even though they're improving in their strength measures, did we actually make an adaptation, or did they just become more, efficient in executing the pattern? And I sometimes wonder if, did we really do anything other than just expose them and build some skill in a certain patterns, or are they going to continue to have, similar issues because there was no true adaptation from, a tissue level that occurred?
Well, that's like the first step, maybe, because regression to the mean would be literal. They would have made the same progress had they not come to see you. But at least you're saying, well, we got the ball rolling to just get them to do something, essentially. Like it was like an accountability thing, and they kind of a structured physical activity. At least we played that role. But to your point, it's once they're done with us, because those beginner gains can be enough for discharge criteria, right? And that's kind of what your point. But you can lose those beginner gains quickly, or once you tap out, and if they don't know how to actually continue to push the needle forward, which by the way is going to require harder work, and there's going to be less gains over time to be seen. So it's not as fulfilling as the beginning, when they're just like everything feels cool and they're progressing literally every time they do something.
Yeah, absolutely. And I mean, that might fall solely on the clinician, right? And maybe we need to do a better job of educating and really actually promoting some sort of behavior change to get them to kind of consistently progress through that, as opposed to just, I feel better, I can go up and down the stairs with less pain, et cetera, et cetera. All right, see you later. So I think that's an interesting thing to kind of think about. And that's one of the things that I took away from kind of like the early part of this article, is just like, man, how often are we kind of just sending people out the door, not unequipped, but without really making it as much of an impact as we could, or that is needed to really set them up for success over the long term.
Anthony's got a comment or a question here. I'm going to lower your hand, Anthony, and then I'm going to unmute you. You should be on, buddy. You hear me? Hear us? I hear static. Anthony. Oh man. All right. I'm going to mute you again. If you can hear us, put your comment in the Q&A. I'll type it, he says. Okay. Benjamin said, I'm reading this in the chat and I just happened to see it, but when I read the section on dosage, what struck me was the transition to self-regulation of dosage. I think this is really important in regards to improving self-efficacy, ownership. Right at the end of the day, we aren't doing anything, they are. Well, we're kind of the guy, like as Kevin was kind of mentioning, we're like the tour guide. So, you know, if they're coming in with, they've never been here, no idea where they are, the tour guide kind of point them in the right direction, make sure they don't veer off course too far. But yeah, obviously they're doing the work. But the RPE is an interesting thing. And I think if you're going to send somebody home with RPE, then you should probably be utilizing it in the clinic with them so that they understand what anchor it somehow so that they get what the ratings are, and don't just have them do exercises in the clinic and then write them a home program that has RPEs and have them try to figure it out themselves, because it won't mean a whole lot to them. But yeah, I think the auto regulation is an interesting piece as it starts to kind of trickle into rehab more and more. So we'll wait on other people to chime in, but I'm going to go through the tissues again. So we talked about cartilage, whereas at least we're minimizing loss, and cartilage loss may have a larger genetic component, like whether you're going to develop OA or not. We're still don't quite understand that or kind of far from it, but you can't prevent it, but it certainly doesn't help if you have it and you're weak and you don't have muscle mass and you can't produce force or tolerate loads and absorb loads. And then bone, this is something I think Rich Willey is one of my go-tos for research and information on bone adaptation. But they talk about that. That's that Lift More trial where they had the postmenopausal women lifting 10 to 15 reps at less than 60% of 1 rep max, or having them kind of work into a program that eventually progressed to 5 sets of 5 at 80 to 85% of 1 rep max. And they were doing deadlifts and back squats and impact loading in the form of assisted jumping chin-ups. So they're doing a program that looks a lot like strength and conditioning, and then found some differences in bone mineral density. So with that, and I think they go into the rest of the paper, just kind of saying that bone adaptation requires a certain intensity of load, which was interesting. And Kevin, you may have kind of more of an idea on this, but there was an interesting point in the paper where they said, well, if you were actually trying to stimulate the osteocytes directly, the mechanical load would have to be so high that the bone would actually break. And so there's this kind of mechanical load cascade that triggers the osteocytes.
Yeah, it's like a backdoor to
yeah
osteoclite activity. The other thing I thought was pretty interesting too in this section was how walking's really not making much of a difference on bone mineral preservation. And that's something that you hear all the time, right?
Yes.
So that was a highlighted point here. I thought was pretty interesting, but that program was phenomenal, man. And like, I don't know how many people are really getting that when we think about it from a rehabilitation standpoint. I wish it was more, but I mean, that's a lot. Like,
well, okay. Postmenopausal woman comes in your clinic. You don't know anything about her. You've got her history. She's osteopenic or just straight osteoporosis. And is your mind going to go to, all right, cool, let me figure out how to get you to back squat, deadlift, and do some pull-up jumps and some depth jumps? Did you see the program at the end that they highlighted? Like depth jumps. And I'm like, oh, damn, but you're right. And so it's not being haphazard. And I hope the authors would obviously say this, like, you have to use your clinical judgment to progress the person to this. And they give some ideas on how to do that. But you're absolutely right. Like, I don't think our minds go there. They don't go there right away. And a lot of times they would even go there, period.
Anthony's question is up there. Do you see it?
Is it in the chat or the Q&A?
It's in the chat. I can read it for you if you want.
Yeah, go ahead.
He said Ben Cormack on the Physio Network has phenomenal master classes. He spoke on pain and strength training. One thing in Britain that they talk about being a large limitation in both physiotherapists and patients to go forward with strength training is pain levels. He talks about physiotherapists get nervous when we hear the patient is in pain. The patients also get nervous if they're in pain, and it becomes a catch-22. And he got his Kalu Summit ticket.
Hey, there you go. Yeah, I agree with you. They didn't really touch on that piece in this paper in particular, kind of like, okay, strength training, but if they're in pain, kind of how to modify. And I don't know if that was
a good example of this right now. I did it today.
Let's
so
hear
I had like a little old lady. We were kettlebell goblet squatting, and got like finger arthritis, right? So couldn't hold on to the weight. Weight vest was perfect for everything. Squatting, step ups, just find another way to load around the constraint of, osteoarthritis of the hand or something like that. So it was like a timely article because it was perfect.
That's awesome, man.
Yeah.
And if you don't have a weight vest, figure something out. Backpack.
There you go.
I do think that's a good question, though, in terms of like the discussion around, maybe this gets to a point where we just need to be better at making people feel comfortable and understand like the pain experience. I think that's what a lot of this comes back to, is getting them to come to an understanding of, what is the sensation of pain, that they're experiencing. I think that's where a lot of this gets pretty hard, because it comes back to that very difficult discussion on trying to make sense of that person's understanding of the pain experience.
Yeah. And it is a catch-22 there's a lot that goes into it. And I wish, because people ask, well, when do you push into it and when do you back off? And it's like, gosh, I've done both, and I don't know. It's almost just knowing the person, knowing their history, their situation. There's an active, I think it's easy when there's like an active inflammatory, it's acute, and there's an active inflammatory response. Like the joint's swollen and it hurts. Let's back off a little bit. But aside from that, there's a lot of intuition that goes into it, and there's a lot of like communication with the other person. It's very difficult to answer the question removed from the context, and I think that's kind of the point you're getting at, Kevin, is understanding their pain experience. I find myself a lot of times giving them the blanket recommendation of, you're allowed to feel your thing as long as it doesn't change the way that you would have moved, or change your ability to kind of push into the task. So I'll say, imagine you weren't in pain at all, and I had you do a squat at a slow tempo or to a box, and you're just pushing, you're using your muscles, and you're pushing as much as you need to, and you're producing as much force as you need to. That's what I would want it to be, but you just feel the thing. But if you feel the thing and you're shifting kind of away, or you're like not pushing as hard as you could because you don't want to feel your pain, we need to change something or have a conversation. And that's like, in general, I find myself saying that a lot, but that's a nuanced conversation. I can't bottle that up and just kind of package it.
Yeah. I feel like the other one that I commonly kind of utilize is like 24-hour symptom behavior, just as some way to kind of gauge dosage. That's one that I find I use a lot too, but it's very hard. I think if we had an answer for that, I think a lot of our problems would be solved, as to how to navigate and balance those two things.
Yeah. But I think that's what makes it skilled also at the same time. When we say like, oh, well, physical therapy, if we're just doing exercise, it's not skilled, coach, trainer could do that. Well, it is, though, because we're navigating this a little bit more uncertainty, within that. We got some good stuff here. So Jose asked a good question. He says, nice to meet you, first of all. Nice to meet you too, man. Welcome. How about applying BFR, blood flow restriction, with osteoporosis patients, since I've seen this in other papers recently? So it would depend. This is my answer, and I'll throw it to the chat. And I think maybe Cody touched on what I'm going to say, but blood flow restriction is more of a muscular intervention. So So it would be good for somebody who, if your goal is, I'm going to do BFR because I want to stimulate some muscle growth or some type of hypertrophic effect. The thing with BFR is you're typically using light loads. So if you look at this paper, for bone and tendon adaptation, you need relatively heavy loads. So BFR wouldn't provide anything novel for bone or tendon. And as I'm saying that, there's that group, that MD group doing the work with ACL, with post-op ACL, where I might eat my words, because they're starting to see, they released an abstract. I don't think the full paper's come out yet, where they're doing BFR for post-op ACL, and they're seeing increased bone mineral density in the BFR groups versus the non-BFR groups. And they're all post-op, so they're all low load, non-weight bearing mostly. So I might eat my words, and Jose, that might be what you're referencing. So, but in general, I don't think BFR for tendons and bones is going to be my go-to intervention. I'm going to use that for muscles, and I'm going to try to get them weight bearing and progress to intensity as much as I can for bone. But what do you think about that, Kevin?
I agree with you. I think particularly when you're talking about something, obviously there's that one, I can think of one paper that kind of questions some of like the heavy loading regarding like tendon adaptations and things like that. But to me, I think that there's enough evidence to say that I would probably go for high intensity loading. I think even in here, we're talking about, 85 to 90% of a maximum voluntary contraction, something that's heavy loaded to me. So I would share kind of your reservations with regard to the utilization of BFR and for things like tendon or bone mineral changes or adaptations. The one thing that might be a bit of a confounder is maybe pain, where you can maybe get some sort of analgesic effect from it there. But I think if we're going for actual structural tissue adaptations, I'm not sure that you're going to see the similar sort of return with the BFR from my kind of current understanding and knowledge of the literature base.
Yeah, but it's one of those things post-op where if there's no contraindications, it might not hurt to have in the program. It's just not going to be the only thing that you have in the program anyway. So,
oh yeah, like post-operatively, absolutely. Yeah.
Yeah. Well, that's where I can't remember the doc's name. I even messaged him on ResearchGate to see if the full papers come out, but like they're doing a whole line of research now on specific bone adaptation from BFR work and randomized controlled trials with that's kind of flying in the face of basically exactly what we're talking about, but it ain't out yet. So, we can only speak on kind of our priors on this.
We have a question. It says, about training to failure, what will be the right scenario to use it?
Good question. So I think that's also a potentially kind of a adaptation specific question. So to quote Scott Morrison, if we're talking about muscle hypertrophy, training to failure is not necessary, but it is sufficient. So if it takes the guesswork out of the equation in regards to, am I providing enough adaptation or enough stress to induce an adaptation? If you train to muscular failure, well, you can't induce any more stress than that to the organism. So yes, it is sufficient, but is it necessary? Do you have to go to muscular failure? My answer would be no. But if you're talking about muscle hypertrophy, if that's your goal, and you're also using light loads, the proximity to failure needs to be pretty close. And how close? Within 3-4 reps of failure, like truly within 3-4 reps of failure, 2 to 4 reps of failure, something like that. So each set still has to be hard. And I think that's the important distinction. Whereas if you're using relatively heavier loads, then your proximity to failure doesn't have to be that close because of the mechanical stress that heavy load put on your tissues. But because light loads don't put that mechanical stress on your tissues, you have to exhaust the motor pool. So you have to get kind of that hypertrophic effect in a different way. If you're talking about strength adaptations, for a beginner, literally anything is going to get them stronger. So like you probably don't have to go to failure at all to get them to produce more force over time. That's just a neuromuscular efficiency thing like Kevin was talking about earlier. And with some of the velocity-based research that's coming out, some of this is pointing to you probably shouldn't be so fatigued that the end of the set are getting really, really slow, because that's not the adaptation that you want. You should, there's a certain velocity cutoff or a certain fatigue cutoff that might preserve strength and give you strength adaptations without making you slower. So in clinic, if there's any questions about it, you can take them to failure to know that you gave them the adaptation that they needed. You don't necessarily have to, but just make sure it's of sufficient intensity from a proximity to failure standpoint or a mechanical load standpoint. And I'll shut up there. What do you think about that, Kevin?
Yeah, so I think going to failure is highly useful, provided you're doing it in something that's, you know, pretty low risk. But I mean, if you have somebody on a leg extension or, you know, shoulder sideline external rotation or something like that, I mean, at some point we have to know that we're providing enough of a stimulus that it's going to perturb homeostasis in some way. Otherwise, we're not going to get the change, like you said right there. So I think it's valuable in that sense, knowing that at least I got a decent amount of stimulus or work done today. But it's also useful, like you said, if we're going to thinking in the later stages of rehabilitation, where maybe this person is now transitioning to doing more stuff outside of clinic or outside of the gym. If you're going to use something like RPE, then they need to have that sort of experience of what a 10 out of 10 is. So I think if you're doing it in a manner that is low risk, you know, something that's maybe isolated, just so they have some sort of reference point in their head as to what that feels like, I think it's incredibly valuable for that sense with like long-term, you know, patient engagement and self-management. But again, to echo your point, you know, because I've been influenced by Scott too, at least you know that you got enough to make some sort of change on that day. So I think I would use it. I use it relatively frequently.
Cool. Same.
Quinn, do you see James has his hand up?
Oh, James, you are on the air. Maybe. I'm trying to unmute you. There we go.
Can you guys hear me?
Yes.
Perfect. All right. A quick intro. GPT student at Columbia here in New York. But I wanted to actually just speak to something that happened in one of my orthopedic classes. So I was creating a treatment plan with my classmates as part of an assignment. And it's funny, this is just going to speak to what Kevin was talking about in regards to, you know, manipulating constraints to be able to, you know, get somebody to work the way you want them to, but still feel safe. And it's funny because I used for the treatment plan, I deliberately, based on the objective findings and all the range of motion assessment, I used like quote, strength-based exercises, something you would see in a normal strength program that my classmates most likely weren't really familiar with. And I think they automatically assumed that it was, oh, this might be too aggressive or dangerous. And I just wanted to bring that up because if you understand how to like manipulate the exercise or pattern, like Kevin was saying, so that it's kind of meeting what that person can do based on your assessments, then you're staying within their capacities. And I think that's the intuition that you're talking about that I feel like is missing regards to like other clinicians who don't really have this background and being able to apply it. I just wanted to bring that up because it was eye-opening because it just made me think, you know, an exercise is just an exercise, but the stuff that we should probably learn as students is learn how to manipulate those exercises to match what we're finding in an assessment. Well, I don't know if you can speak to that or if that makes any sense. I just thought it was something important to bring up regarding like what I was learning in school.
Oh, I think it's super relevant and a really good point. And the more I think that type of comfort level with this stuff comes with reading this type of research, but then actually implementing it. And maybe you're more comfortable, you know what, like if you've never really written a strength training program and let's say you're in school or you're a clinician and you're not necessarily comfortable now introducing that to your client base just yet, you know, you should. But even after reading papers like this, implementing in practice is a whole different ballgame. So maybe you do it for your friends. It's like, hey, you know, like, how about I write you like a 4-week strength training program just so I can get some reps in, you know, and you use that as skill practice as a clinician coach to get comfortable with responses. Okay, then how do I navigate when things are going well? How do I navigate when I need to modify or things are not going well? And the more reps you get in that way, the more you'll feel comfortable doing it in the clinic, and everything won't feel so novel and new, you know, when you run into a roadblock or something like that. But I think being okay, like the word intuition just kind of makes me shiver a little bit, but it's an intuition that's based on your priors in experience, but also in what you understand from the literature. And that is kind of what guides your intuition. And then you can go back and reflect on that and go back and look at these references to see if you were on track and that type of thing. But I think you just got to get your reps in. And James, you're coming into the program with maybe a little bit more of that experience than your classmates. And that's probably why you feel a little bit more comfortable dealing with some of that nuance. I wanted to hit on, because I don't forget it, but I just saw, it's a question, it's a good one from Ben. He said, maybe this is a little premature, but it's not. But he had a question about the tendon loading. So if you go into the paper again in section 3, they talk about strength training's effect on tendon adaptations. But in the paper, they recommended 5 sets of 4 at 85 to 90% of maximum volitional isometric or maximum voluntary isometric contraction, with contraction and relaxation duration of 3 seconds each. And Ben's question is the contract relax duration referring to the time each rep is performed? I was struggling to picture what this looks like in a clinical practice. Yes. So Ben, it's maximal voluntary isometric contraction. So in a lot of these papers, and I think that exact protocol is actually coming from a Kubos paper, Kubo, and he's a researcher that you'll see all over tendon land and isometrics land, but a lot of times they're doing those on leg extension machines. So you kick out, or like a bicep curl on isokinetic or something like that, but you kick out maybe 60 degrees and then you hold for 3 seconds and you relax. Or it's a push. You know, they've got the machine set up to whatever knee angle they want, and then you just kick into the pad for 3 seconds and then you relax for 3 seconds, kick into the pad, relax, repeat. And they take a maximum force reading in the beginning so they get your 100%. And so 85 to 90% of that is where you work. So when you're kicking into the pad, they're measuring the amount of force and they want you within that percentage of your maximum. And so so it's not like a back squat. Maybe you were picturing something like that, or a bench press where you're like, how the hell are you doing 3 seconds on and off like that with an open-ended or open connect chain exercise or a barbell exercise? But no, they're usually isometrics. But to that point, I think, first of all, tendons, if we can get into that a little bit, tendons, as the paper alludes to, are contraction type agnostic. Even though we go into school learning about eccentrics, because that's where kind of tendon loading began way back in the day, the tendon responds to tensile load. And you get tensile load to the tendon, whether it's eccentric, concentric, or isometric. And isometrics are really controlled, and you get to use the exact angle and the exact amount of force and the exact exercise that you want. So they're like really, really useful for tendon training. And that's where they're pulling that protocol from. But it's the same type of thing as bone. It has to be of a sufficient magnitude.
Alexander.
Tendons, yeah.
Sorry, go ahead.
No, you go.
Alexander also had another question. He said, the study talks about how past loading behaviors don't really predict cartilage morphology. Unfortunately, summer courses and work didn't leave me time to read through the references, but is there anything that acknowledges range of motion and mechanical loading history and cartilage morphology? Jeez. This is to say, does greater range of motion induce more significant cartilage health differences? I would assume so, but I didn't see anything mentioned in the paper on range of motion.
Yeah, I'm not sure. In the paper, it was more of just absolute load versus unloading, and loading the cartilage does not, because cartilage is avascular, cartilage doesn't seem to adapt favorably forward the way that bone, tendon, and muscle do, but it does backslide if you don't load it. So at minimum, you're minimizing your loss, but they didn't necessarily mention range of motion. So I don't actually know, and I'm not familiar with any of the literature that's parsing that out. Kevin, are you?
I am not. That was my understanding as well, though, is that it's something that can be relatively easily kind of depressed, but it's hard to elevate in terms of cartilage health based off of, history of loading or lack thereof. But with regards to range of motion, I don't know. Obviously with hypertrophy, there's evidence to suggest that full range of motion is something that is necessary for maximum adaptations, but that's a good question. I don't have an understanding in that area.
You got anything else, Taylor?
We have a bunch.
Okay, let's hit them.
Ellen said, after you've worked with someone through that first cycle, when they get general strength effects, what are your favorite feasible ways to anchor 1 rep max for elderly or frail individuals safely so that you can use a proper stimulus for change?
You could do, this is where RPE might come in handy. You could do a set to maybe technical failure. And I think Paul put this comment in the chat, where it's like, say you're having them do a goblet squat, holding a weight in front of them to a box. Super safe, and maybe even put them on a metronome. So they're doing like 3 seconds up, 2 seconds down, or vice versa, or whatever you want to do, but you slow it down so that they're not getting crazy. And you say, okay, so we know how much weight you're using. We know the height of your box. You're going to do as many reps as you can with this weight into this box, except you got to stay with this tempo. And it's a metronome that they're going to the beat. And so as soon as they either start fighting the metronome or plopping or tipping forward, you end the test, but you count the number of reps from before technical failure. And what's technical failure is based on your eyeballs. So we can argue that until we're blue in the face, but at least gives you some anchor. And then you can say, okay, you did this many reps with this amount of weight. You could program then a percentage of those repetitions. So let's say they got 10 reps, just to make it easy. You could say, okay, we're going to do multiple sets of 6 or 7 or 8. Because you would think about, okay, now 6 to 8 reps is working 60 to 80% of where we just failed. So you can kind of anchor it that way. And it seems kind of convoluted, but really you're just kind of manipulating all of these variables for a test that's repeatable. And then you back off one of those variables and accumulate some work within that, but still pretty close to that. So like if now this person does sets of 7 or 8, that's going to be pretty tough if you have her do 2 or 3 sets of that, because at her best, she only did 10 reps. But that's kind of how you can back it off a little bit, but still kind of keep relative intensity kind of high. And then you can progress over time, obviously holding a heavier weight, not taking her off the tempo. So allowing her to kind of self-select the tempo. Maybe you're even cueing her to stand up really fast so we can work on power and rate of force. But that would be one way. Kevin, you have any suggestions on that?
I would say the other thing that you can do is if you have access to like a dynamometer for like a mid-thigh pull, where you just have the person go in there and just pull as hard as they can. We've talked about this before, just to get an understanding of how much force they can produce. I think the other thing that's useful is like the DAPRI model of loading, where you're kind of starting very far removed from anything that would be in the range of failure, going like 50% of a working weight to 75 to a full working weight for the desired rep range. And then just based off of how many repetitions they perform before, volitional failure or technical failure, whatever you want to call it. Then you have kind of an algorithm to adjust weight up or down based off of that. So I think you could still probably get a sufficient stimulus without actually taking them to a 1 repetition maximum, or even using something that would maybe be a little bit more, quote unquote safe, using like a 3 RM to estimate a 1 RM or a 5 RM or something like that. So that's probably the way that I would go about it. I don't know that I'd say, at least personally, I've not taken like a rehab client to something like to failure where they failed in something like a barbell back squat.
Yeah. So the DAPRI, for anybody who's not familiar, is the daily auto-regulatory progressive resistance exercise. It's just auto-regulation. It's basically how many reps can somebody do at this weight dictates the weight that you use for the subsequent sets and also the weight that you use for subsequent sessions. And it's really nice. It was actually introduced in the collegiate setting by Brian Mann, And in fact, it's reference 219 was his original paper. And I'm going to post the title of that paper here in the chat, and you can just copy and paste this right into Google if you want to learn about DAPRI, which is something that you can use in the clinic. And it dictates, it dictates loading for that session and the next session. It's pretty cool. It's really, really useful in the clinic. Takes some of the guesswork out of the equation. And also, you know, like undershooting, as long as you're like moving the notching up on a variable, and maybe you choose that variable to be external load over time, it's not the end of the world if you haven't anchored yourself to where their maximum actually is. But you know that if you're moving the needle forward in one of those training variables, you're at least going closer to whatever that maximum is. So it's certainly not perfect, and it's not as auto-regulated, but you're still making progress.
So bouncing off of that question, Dan asked, is there a psychological angle that training to failure can impact? For example, an athlete near ready to play / tail end of rehab or strength and conditioning program who just needs to do something very hard with their body to build a sense of trust for how they handle intense physical situations.
Well, I think there's potentially something to that. I mean, you could go the other way and within season, going to muscular failure when they maybe have like a game the next day or something, like you make them sore, like that would be bad. So I think in either direction, there can be some use for that, especially if their sport, let's say they're a CrossFitter and they're going to basically feel muscular failure every single time that they walk into the gym in some capacity. Doing some AMRAPs, which they probably already do, but having those in the program sprinkled in every block with a particular exercise is not a bad idea. At least you anchor RPE and you teach them what hard feels like. And for powerlifters, for example, the sport is grinding. Powerlifters, the good ones, move their maximum much, much slower than, say, collegiate sport athletes move their maximum. Meaning they're both maxing out 1 rep max back squat, but the powerlifter is able to grind a lot slower because that's what they've been tuned up to be able to do. So if their sport kind of requires that, it's not a bad idea to get them into that feeling. But, you know, I think we'd probably need more of a specific context to say when and how much and who. But yeah, I think it's a good question and worth a conversation.
Yeah, I feel like you could probably even take that even further, just the psychological aspects, or, you know, like the process of engaging in strength training in general, not just, you know, for an athlete or taking them to failure. I think there's a lot to be said about that. And many times I wonder if that's kind of more influential in, you know, positive outcomes that we see more than anything. Just as we touched about early on, you know, maybe we're not prescribing in a way that is really making true tissue adaptations, but for some reason, the engagement in the process of resistance training is providing, you know, a very powerful stimulus to the person in maybe another way that's not tissue specific.
Yeah, I think failure training, it almost gets strawmanned a little bit, because it's not like people are training to failure on every exercise every day. So that would suck and would probably burn you out and maybe increase risk. But the papers that I've read that show failure training is at increased risk of injury, a lot of them aren't actually showing any data. It's more of like hypothetical. So, you know what I mean? So like, yeah, it would make sense that one person trained to failure versus another person not trained to failure, the one trained to failure may be more at risk. And then we take that statement and we say, oh yeah, that must be true. There's actually not a ton of data to support the safety risk of training to failure, because you wouldn't do it with your entire program, you know? So like Kevin, I pick my spots, but it definitely teaches the athlete, you know, what hard training is, and you can make sure there's constraints in place, even if it's just you saying, all right, let's cut it off there. Like knowing they could have maybe ground through a couple more reps, but it would have looked a whole lot different than the first couple reps looked. You can kind of put those boundaries around them, but still kind of reap the benefits of hard, intense training.
we got some more questions over here. Adrian said, I agree that we can do better in terms of encouraging sustainable behavior change in education. For many clients, insurance may impose a duration constraint that limits our ability to progress them over time. Perhaps group training or virtual classes may be cost-effective alternatives to aid in this transition, especially to ensure better accessibility to lower socioeconomic status populations. What are your thoughts or experiences with promoting accessible resources for continued strength progression and long-term sustainability?
I personally love the idea of group training as a kind of a whatever you would want to call it, like a continuation program or a bridge program or whatever, because it makes like, yeah, okay, we discharge them, like we get them basically, it's like an entry-level physical therapist. Okay, you went through 3 years of DPT school and then they just throw you in the clinic. Oh, you're entry level now, but you're like, I don't really know shit still. I haven't really worked with that many people, and now I'm a PT. So, which is why people are pushing for residency. Is a different conversation, but it's kind of the same here. It's like, okay, you're discharged, you met the minimum criteria, good luck. But that doesn't make sense, right? For long-term change, but it can be expensive to keep coming back, especially if insurance stops paying for something like that. So yeah, no, I think group training is a really cool. I know a lot of clinics within the clinical athlete community or have some type of program like that, and it's viable for the business too, to be honest. Like if you own the business, if you're a good PT, you're always sending your business out the door, and you don't want to be biased by keeping them in your plan of care when they don't need to be. So if you had a program like that was informed, they were, the consent was informed, and they said, yes, I want to continue with this process. And I think that is a really, really good solution.
I agree. I think that's the ideal model, kind of the seamless transition from the rehabilitation into the group fitness, strength and conditioning side of stuff.
Derek said, how are we able to adapt the home training to provide heavy load to patients if they don't have access to gym or weights or the financial ability to pay for a membership?
Yeah, so good question. And this is where isometrics come in really handy, because there's a strength coach, and he's out in he's gonna be pissed, New Zealand, I think. So he's a head strength conditioning coach. His name is Alex Natera, and I'll just put his name here in the chat. But he's known as the isometrics guy just because he does isometrics with his healthy athletes, but obviously he does everything, comprehensive strength conditioning programs. But he made this big thing, and it's actually a free presentation on VALD performance. They've done a ton of really cool webinars lately. So if you Google Alex Natera VALD performance webinar or something like that, he actually did an entire presentation on staying strong during quarantine. And so his thing is like pushing against immovable objects. You can create force. So it can be your car, you're doing like an isometric deadlift on your bumper, or you're getting underneath like a bar or something, anything that's not going to break when you push on it, and you butt it up against something that's not going to move. I don't care if it's a tree, and you push, and you can do that at varying angles. So with muscle hypertrophy, it's easy. It's simple, I should say. You can move light weights close to muscular failure and at least mitigate muscle loss and probably gain a little bit of muscle. Each set is going to suck. Lightweight hypertrophy training sucks because it burns like hell and you have to keep pushing through. But when it comes to tendon and bone, like that may not do the thing as we talked about. So find shit that you can push against and watch that webinar. So I'll stop there, but that's what I did with a lot of my athletes. We would do like isometric split squat holds, where I'd have them either load up a backpack as heavy as they could possibly hold it, or if they had straps, like a towing strap that they don't stretch, they don't break, they're strong as hell. You can put it under your foot if you're in a split squat position, and you're holding it with your hands, but it's also under your foot. So if you push your foot, if you try to stand up, you're not going to move because you're holding the strap, if that makes sense. And the strap's not, but you can do that for this kind of the same isometric protocol that you saw in this paper. So it ain't perfect. You're not going to win any gold medals just training isometrics, but in a period like this, you will at minimum mitigate that neuromuscular efficiency loss. Like your body will still know how to produce force. So I'll stop with that. So Mike T. Shannon says Mike T's experimentation with toe straps and crane scales. Mike Tushier has been on the ClinicalAthlete podcast. So he has he's graduated from the crane scale. I shot him the crane scales that we were using in the clinic. He started with that, but yeah, so Mike T was doing the same thing. He was traveling a ton. He moved, so he was spending a lot of time just on the road, and he's been doing one of the strongest guys, at one point, strongest guy in the world. He's doing isometrics with toe straps and crane scales and just trying to keep the juices flowing, keep stuff clicking. All right, now I'm done.
All right, I have another question. Cody said, have you guys ever used or seen the utilization of various periodization strategies within the rehab setting? All I've seen and discussed in DPT school is basic linear progression.
We had like a single lecture on periodization in PT school. It wasn't a lecture. It was a couple slides, and it was like linear periodization, reverse linear periodization, and kind of an undulating, basically daily undulating periodization, where you'd have like a moderate, light, heavy day, which, I mean, is a decent place to start. But it wasn't much. I will say though, Cody, at least in my program, they said right off the bat, like, we're training you to be a generalist. So I don't necessarily fault them for the core curriculum, not providing more advanced training principles, but I think what we're starting to see is programs giving more options for electives. Like at Quinnipiac, they've got Eric Lagoy's elective for strength conditioning. At Zach DeBoer teaches one also up in Boston. Same type of deal. So I think that's going to be how it trickles in with these elective courses, where third years or end of second year can start to kind of veer off if they want to and do some of these things. But look into DAPRI. That link that I sent is a really good one in clinic. Scott Morrison is probably your go-to resource there for like utilizing S&C principles in clinic. Dan Lorenz and Scott. Oh, there you go.
I mean, my experience in PT school was similar. It was an elective based stuff, but in terms of like advanced periodization within the clinic, I don't know. Sometimes I question the utility of it. Sometimes I think that I don't know why we sometimes bash on things like a linear progression, especially if we're thinking like post-operatively, where you're with this person for an extended period of time. And you can get a lot of changes coming off of post-op with just a general linear progression. So I don't know that there's always a need for advanced periodization schemes in the rehab setting, but it's going to be something that's probably case and context dependent.
Some people are dropping links into the chat, guys, if you want some resources on that stuff. And Paul asked, how do I know what people are doing at various schools? Well, they're in Clinical Athlete. So I did a lecture for Zach's program, and I did a lecture for Eric's program, and Eric has posted threads. Like when he first started that elective course at Quinnipiac, he was discussing how to kind of start it in the forum. So I just pay attention to the peeps. Do we got any other questions, Taylor? I don't even know if we covered the paper all the way, but these questions are good.
I don't have any in the Q&A box. Adrian just said, perhaps advocating for strength and conditioning education also needs to happen more at the APTA level to ultimately incorporate within the CAPTE requirements and NPTE exam. To the best of my knowledge, schools currently offering this course only do so as an elective, but strength is important for everyone. Unfortunately, will probably take a while and many political hurdles, but doesn't make it less important.
Yeah, so we're getting specific to physical therapy, which this obviously is not, but CAPTE is the accrediting body that oversees all the programs, and I'll suffice it to say it's an uphill battle. I'll just put it that way. Well, gosh. So in the paper, if you want to look at section 4, if you're just curious, there's the kind of the practical recommendations, and they do. Can I just bitch for a second? Because I love this author group and I love the researchers and all these things, but it drives me insane when the table is the landscaped instead of like, what do you want me to do? Flip my computer to the side? God damn it. It's like the most important part. I want to see the program. That's how I read it. I literally read it like this. Sorry, I know, it's like, stop crying. They're giving you stuff. You got to work a little bit. But table 3 is kind of an outline, an example strength training session for a postmenopausal woman with low bone mass. And they go through a familiarization phase, a strength endurance phase, which is basically like lightweight, lower reps, which is maybe where we usually stop them in clinic. And then phase 3 is strength emphasis. So lower volumes, heavier loads. And if you look at the exercises, even in the familiarization phase, the impact, so they've got like the strength training exercises that are kind of your basic patterns that we may be familiar with. And they've got some dosages from a percentage-based perspective and also from an RPE-based perspective. And then they've got impact loading, which is important for bone. So I thought that was pretty cool. And the way that they did it was, at least for the subsequent phases, they basically intersperse them within their strength training movement. So like in a rest period of their squats or their deadlifts, they'd go and do some like whatever jump drill. But in the familiarization phase, they got snap downs, which if you're not familiar with a snap down is basically you standing tall and then you jump down into position. So you essentially mimic a landing, but it's lower impact, but it teaches you how to absorb force. It's a nice entry point to deceleration and load absorption and landing. And they've got some other things too. And then they progress. But postmenopausal woman, when you get to the strength training side of things, 4 counter movement jumps, 3x3 hurdle jumps. Well, how many clinicians are doing that stuff with that population? And that doesn't mean it's right just because it's in a paper, by the way. So you might make that argument. I want to make that perfectly clear. But I think it's the idea that we should be making it hard if we're not trying to get them good at hurdle jumps. We're trying to create adaptation.
Yeah. Specific. Well, I mean, even just to touch on like the periodization part here, I mean, this is a good detailed program that's pretty much a linear periodization. You're starting with a little bit of general physical preparedness, a little bit of hypertrophy work, moving into strength, laying the base for more sort of like power elastic activities. So like something like this, like I don't see why necessarily for a majority of rehabilitation, you need much more than that, right? Obviously it's going to depend on the population that we're talking about right there, but this is a good example of a well-executed linear periodization that goes through phases, laying the groundwork and before advancement that I think is excellent.
And I was a little disheartened that they took out a squatting pattern from phase 3. There's no squat there. It's just trap bar deadlift. But you can make a trap bar deadlift squatty. So whatever. They're not powerlifters. Cool.
I have one more question.
Okay, let's hit it.
Derek said, in a society where we struggle with meeting exercise requirements as is, how do you recommend approaching the idea of heavy resistance training and higher intensity training overall with patients?
How do you do it, Kevin?
I don't know if that I'm successful. I think you got to kind of meet the person where they are. In some cases, just getting them to engage in some sort of general physical activity, whether that's walking, is sometimes the concessions that you have to make. So it's going to be very much dependent on the person that's in front of you. And in some cases, it might just be a win just to get them to move a little bit more, period. So I don't have a good answer to the question. I think it's hard, but just kind of recognizing that you're not a failure if you can't get the person to adopt, every ACSM guideline as it currently is for Americans, because we know that most people just aren't in general.
It's definitely hard. I think this is where the communication piece comes in really handy. And so basically bottling up what we had just talked about, where we're trying to elicit specific adaptations and making that point relevant to the person so that they care about it. So go back to their goals, establish what the heck they want to do in their lives and why they're coming to see you, because they can't do those things the way that they want to do them, or they're scared or whatever it is. and you say, okay, what would you think about? So like almost ask their permission and kind of get them to kind of come to the realization, what would you think about, doing some things that may look like they're not for you? Because if they come into my office door, they see a bunch of people doing snatch and clean and jerk and squats and deadlifts. It's like, whoa, am I in the wrong place if they're a certain population? But like, no, those things, well, it can be a sport, but what can also do is make these changes to your body so that you're a little bit more resilient and robust. And what it'll do is it'll transfer to you being able to do more of the things that you want to do. And so you can kind of frame it that way so that they know that you're not just being trying to make them a weightlifter or just being a bro about it. There's an actual reason, and it is rooted in what they want to do. So you just bring it context to their goals and what they want as best you can. And I think that will help to maximize the chances that they adhere. But even then, it's difficult. It's maybe easy in the beginning, like if they get them to buy in, they're real excited because it's novel, but like, what do we say? It's cool in the beginning just because anything new is cool and the beginner gains are cool. But then like several weeks in, when the actual gains are harder to come by and you have to do more to get them, it becomes even more difficult. But that's just when you come back to the conversation from day one. You say, remember what we talked about? Because if you have that conversation, now you can come back to it. If you never have it, it's hard to then like remind them of that when they're, when they're 5-6 weeks in. So that would be my answer to that. Cool. Is that it, Taylor? What'd you think about this paper?
Definitely confirmed my bias.
Hey, there it is.
Derek, open a gym and practice out of that. There you go.
Problem solved.
Then it's in your programming. That's what I do.
Heck yeah.
Yeah, I really liked it. I liked that it kind of covered a lot of different aspects of like different tissues in the body, but also like psychological things like depression and that wheel of like strength training stuff where there's all those different arrows. I think that's fantastic. I mean, there's so many benefits to it. So I really liked it a lot. I had some questions on like I'm curious as to why there were do the little arrows on the program that's on there, does that mean it's superset or is that the progression that they're making? Like they're going from goblet squat to split squat? Or is that like in between they're doing one and the other?
I think that was designed to be like a progression from like a bilateral squat pattern to like asymmetrical.
Okay,
like
that's
that
what I
was
thought
the way
too.
that I interpreted it.
That's what I thought too. Yeah, I was curious about like some of the exercise like prescription and like what was chosen and some of that, but I like that there's like it starts with like a really good general strength training. I like it all. I think it's good.
Yeah, like Kevin said, this author group, it was the power and strength training and rehab paper that they actually cite, which if you missed that journal club is reference 229, strength and power in rehabilitation, underpinning principles and practical strategies to return athletes to high performance. I just paste that title into the chat, but the same author group. And the lead author, Mastroni, is a clinician. He's a physio, I believe. The rest are all either kind of clinical researchers or strength and conditioning coach / researchers, I think. I could be wrong about that on Konstantinos, which I just butchered his name, but they're based out of the UK. Sukamel is based out of the United States, but really, really good author group. Paul Comfort has done a whole lot of work on strength training and power and strength, and so Sukamel. Chris Bishop does a ton of awesome work on like asymmetry and change of direction and deceleration. So that's really, really useful for ACL rehab. Chris Bishop also has a podcast, really, really good podcast that he's had a lot of people on. So that's one thing that like with these papers, you don't just read the paper and then you're done with it. The author, if you like the paper, check out the author group. Follow them on ResearchGate, follow them on Google Scholar, and then you can see their line of research and it'll probably, pull you into lots of different stuff. Cool. Okay. We're good. That was an awesome session, guys. Thanks, Kevin. Thanks, Taylor. Thanks everyone who joined in.
Thank you.
Yeah, whether you were fly on the wall or ask some questions. It's always useful for us. So we'll see you next time.
Hey guys.